You're tuned into Human Anatomy and Physiology 1 and the fourth and last section in a discussion of Chapter 6 of the Merriam-Pearson textbook. And we've so far talked about where bones come from in development and how long bones grow and remodel. And now this last section we'll talk a little bit about bone repair and also about some diseases of bone. So let's take a look. So bone breaks, that's the subject of this first section. Bones may break from sports activities over stressing bones beyond their capacity to withstand those forces. But oftentimes bone breaks come because there's some issue with the bone. And so later in life, the bones tend to lose some of their density and they become less stiff and less strong. There's a lot of bone breaks. We'll talk more about that loss of bone density later on. So there's some terminology associated with bone breaks we could look at. One pair of terms here, antonyms, has to do with the position of the bones after the break. If the bones stay in their normal position, but there's a break in the bone that needs to be healed, that's called a non-displaced fracture. More often, the bones will be out of position. They'll be displaced. For example, there's muscle tone typically. When you break a bone completely through, the tension that's normally present on those muscles will move those bones out of position, but oftentimes various traumas result in displacement. Sometimes a bone is not broken completely through. There could be a stress fracture or a partial fracture. That's called an incomplete bone break versus a complete bone break. And then finally, open fractures, more often called compound fractures, are ones in which the bone is visible from the skin surface. When you hear compound, you might be tempted to think, oh, that might have something to do with how the bone has broken, the pattern. Nope, it's just about whether or not the bones penetrate through to the surface of the body. Closed fracture or a simple fracture is one in which the broken bones are retained within the body tissues. So let's look at some common types of fractures. Here's a fracture that's probably most common in people with, again, loss of bone density, elderly people or people with bone disease, in which the bone kind of shatters when it breaks. So that's called a comminuted fracture. You can see that there's multiple pieces here, whereas a youthful bone probably would just break across these two bones. A compression fracture is one in which the vertebrae are crushed. If there's a fall from a height and you land on typically the person will land, even if their feet hit first, they will then strike the spine downward. If the spine happens to strike at the tailbone, often a vertebral bone may be crushed. It's also especially true, again, if someone has osteoporosis or some loss of bone density, and that bone will collapse. A spiral fracture is mostly common in sports injuries, especially when playing on astroturf, so that if someone's foot is planted and their body is undergoing a rotational movement and there's some maybe contact with another player such that the foot can't be removed from the surface and the bone experiences that twisting force, you can have a spiral fracture. Epiphyseal fractures are ones in which the epiphysis is sheared off from the diaphysis through the cartilage growth plate. That's always a fear when young children play contact sports. There'll be an injury in which the growth plate is sheared, and that's a problem because that's where the bone is growing in length. And if it's occurring during a growth spurt, that bone will probably result in a shorter bone than in the paired limbs. So there's going to be a mismatch there, perhaps. A depressed fracture is a fracture of the skull bone in which the surface of the skull bone has been broken inward. It's considered an actionable situation if it penetrates too deeply, but that depression of the bone there is called a depressed fracture. A green stick fracture is common in youthful bones. If the bone breaks partway through, the bone is so resilient that even though it's been overstressed and it breaks, part of the bone remains connected, and we have that green stick fracture. So when we take care of a bone break, the first step in treatment probably is to do a reduction, other than to actually analyze by x-ray and find out exactly what's going on. Do a reduction, reposition the bones. If it simply is a matter of positioning from exterior of the body, it's called an open or a closed reduction, I'm sorry. If some surgery is required to place some plates or pins in position to hold things in place during healing, it's called an open reduction. Immobilization is essential for healing of a bone. Bone is highly regenerative, but we have to have immobilization, or the bone repair will not be able to complete. So here's a series of steps to help us think through some of the things that happen between when a bone breaks and when it is completely healed. It's kind of analogous to when we talked about the processes by which bones develop. So we'll just break this into 4 kind of steps, not that they actually occur in sequence biologically, but just a way to intellectually organize our thoughts and be able to remember what's happening with bone healing. So when you break a bone, bone is highly vascular tissue, and there's going to be a hematoma. That just means a blood clot. There's going to be torn blood vessels, blood's going to leak out and clot, and that's going to be a painful proposition. Some nerve endings are going to be massively interfered with. There's going to be swelling, inflammation. So here's a little cartoon suggesting a hematoma. Kind of neat and tidy the way they drew this, with the periosteum hasn't even been disrupted. It might or might not be the case. Once that hematoma forms, immediately phagocytic cells come in, and like macrophages come in and start clearing up debris. Macrophages will gobble up dead cells, denatured proteins like collagens and so forth, and blood clots, all kind of debris that's there, and start cleaning the place up. There's going to be hypoxia in this area of the body, and there are signals released from cells in the region that they're hypoxic, and they will release growth factors causing angiogenesis. Blood cells are going to start growing into this area and will replace the blood supply that was lost when all those vessels got torn during the trauma. Fibroblasts will come in, and remember, fibroblasts are those overzealous, almost workhorse kinds of repair cells, and fibroblasts will come in and start creating collagen fibers, and that's what they do. They make collagen, the ultimate, the most prevalent building material of your body. Also, some chondrocyte-like cells and osteoblast-like cells are going to come in and start making bone matrix and cartilage matrix. We've got this kind of amalgamation, this temporary repair tissue of all kinds of good stuff happening that with respect to collagen fibers and extracellular matrix that of connective tissues, and we're going to call that the fibrocartilaginous callus. Couldn't get that out. Fibrocartilaginous callus. So here's a picture. We've converted the hematoma, the blood clot, into something much more substantial. It's still flexy, but at least it's starting to look like something. We've got some collagen in there to give it some strength. We've got new blood vessels growing through there. The next step is to really turn that into some bone tissue. So ossification of that bone, of that fibrocartilaginous callus, will create a bony callus. Some new trabecula will form, and we'll have some fairly tough stuff built in. The union between the bones is getting quite strong over that 8 weeks or so of time. And then finally, some remodeling is going to take place. Here we see some new spongy bone that has knit together these 2 broken bones. And now we're going to remodel that and kind of make things resemble more what the original structure was like. We're going to put some compact bone on the surface of this, the diaphysis of this long bone here. And so we're going to have some good, strong, compact bone there, and get things back to the way they were. One thing that is interesting, it isn't necessarily so that any of the cells recognize that, oh gee, the medullary cavity should be hollow and now we've put some bone there. It wouldn't necessarily be that there would be all of a sudden this removal of all this bone. There may well be a case in which you'd find an x-ray of someone of a wound heal from many years before that still had some bone tissue in there. But anyway, remodeling to make things about the way they were before. A very tough, successful repair job. So that's the wound healing or tissue healing process with bone breaks. A couple of homeostatic imbalances associated with bones. And here's the name of a couple of things we'll talk about right now in succession. We'll start with Osteomalacia and rickets. They're essentially the same thing. Rickets is what it's called when this condition presents in childhood, osteomalacia in adults. So if the bones are not sufficiently mineralized because of a problem with insufficient access to calcium, in other words, dietary calcium is insufficient, or there's not enough vitamin D, because remember, you need vitamin D to absorb calcium in the intestine, then the bones become too flexible. They can't support the loads that are normally placed on them. That's called osteomalacia or rickets. So we actually have bowing or breaking, painful breaks of the bones because they just can't support the weight of the body. And here's an x-ray of rickets in a child. You can tell it's a child because, right, we have secondary ossification centers here in the epiphyses of these long bones. We can still see a very prominent growth plate. In fact, these epiphyses aren't even completely ossified yet. And we see this abnormal sort of contour of these bones of the lower leg, the tibia and fibula. Osteoporosis is a condition in which there's a pathological degree to which the bones have lost bone density later in life, right? So we have a certain amount of bone density. We said that Wolff's Law refers to the fact that if we load up the skeleton, we exercise, then the bones will increase in density and we'll have lots of nice calcium phosphate hydroxyapatite in there, making the bone matrix very, very strong. Well, later in life, some people develop a very bad loss of density. Everyone loses bone density as they age. The more you exercise, the more you can stave off that loss of bone density. So exercising, getting in a habit of exercising now is a great idea, and then it'll be more easy to maintain that throughout your life, and your quality of life will be improved. But some people have a genetic predisposition to really lose a lot of bone density, and that can lead to a disease state in which the bones start looking very moth-eaten and thin and wispy. So here we have some trabecular bone and a healthy bone, an x-ray of a healthy bone, and here we have some trabecula that have been really plagued by loss of calcium and phosphate deposits in there. It's called osteoporotic bone. Osteoporosis creates some characteristic presentations. Here's a person with normal stature and posture, and we can see that there are cervical, thoracic, lumbar, and sacral curvatures, which are normal in the spine. They arise during childhood development, infant and childhood development, and as osteoporosis begins to weaken, especially the bodies of the vertebral bones, the spongy bone in the bodies of those vertebral bones sags, and the curvatures of the spine become exaggerated. And sometimes the neck will actually align almost horizontally with the head facing, with the face facing the ground and the top of the cranium facing anteriorly. In a very severe case of osteoporosis, you can recognize the characteristics of somebody with this malady by their posture oftentimes. So what causes osteoporosis? Age, but especially loss of androgens and estrogen. It's estrogen and testosterone that are very important drivers of the maintenance of bone density in addition to exercise. And after menopause, women tend to lose a lot more bone density than men do as they age. So women are especially at risk for a lot of bone breaks later in life because of osteoporosis. So it's very important to think about how to maintain that bone density as you age. So what can we do about that? Well, here's some more risk factors for developing osteoporosis. Let me just insert that in there. Not enough exercise, right? If you leave your skeleton, don't place the loads on it. Wolff's Law not only says that exercise increases bone density, sedentary behavior will reduce bone density and the bones become weaker. If you don't take in enough calcium or enough protein to make the collagen part of the extracellular matrix, bones will become weaker. Cigarette smoking is correlated with osteoporosis. Unfortunately, if you have ancestors, mother, grandmother, or whatever that have osteoporosis, the chances are good that you may develop osteoporosis. You'll be wanting to be especially vigilant about your exercise regimen and so forth. There are certain hormone diseases that can lead to osteoporosis. Hyperthyroidism. leads to osteoporosis. Diabetes mellitus, hyperthyroidism, we have too much metabolic activity of some of the cells in the bone, and perhaps they're not settling and putting the matrix in as they should. What can we do about it? Exercise. Making sure you have sufficient vitamin D circulating, and if necessary, take vitamin D supplements. It's a cheap, effective way to make sure you have enough vitamin D to absorb the calcium in your diet and make available the calcium for maintaining bone density. If you're prone to osteoporosis, or if you, after menopause, you begin to develop osteoporosis, one thing you can do is take hormone replacement therapy. Estrogen levels go down. There are some synthetic hormone products, medicines that can be taken to replace the estrogen, which will combat osteoporosis. The downside of, or controversial side of hormone replacement therapy is that after it was invented as a really fairly miraculous approach to getting rid of some discomfort associated with with menopause, but also maintaining bone density, it was discovered that people that took these hormone replacements became more susceptible to heart attacks, especially women, right? Women have a lower rate of heart attacks, and now they started to have a couple of % increase in the likelihood of heart attacks, strokes. Breast cancer. Many times breast cancers and ovarian cancers are driven by hormones, and so we add a hormone in there that might be likely to drive the progression of a cancer. That would be something undesirable, obviously. So there are some other treatments that can be used. Bisphosphonates like Fosamax kill osteoclasts, and if you remember, osteoclasts are the cells called upon to break down bone matrix when blood calcium goes down. Excuse me. So remember, these are things we're playing with fire a little bit here. We don't want to inhibit osteoclasts so much that we can't maintain good bone or blood calcium levels. So osteoclasts have a job to do, but we may want to be able to just subdue the osteoclast activity enough to slow down the loss of bone density. Here's an antibody medication that also prevents the production of osteoclasts. We're also targeting that cell type to prevent loss of bone density. Pagets disease. Pagets disease is a poorly understood disease in which there's a very high rate of bone turnover, especially in certain parts of the skeleton, the spine, the pelvis, the femur, but possibly also in the clavicles. We have this reduction, taking out bone matrix and producing bone at a very, very high rate, and it's not properly matured. You wind up with some weak bone that is poorly constructed, that has too much spongy bone, not enough compact bone, and it leads to some problems. Here's a picture of a normal pelvis and femurs. And then here's a picture of this moth-eaten appearance of the bones with Pagets disease. We're taking out too much of the existing bone and quickly replacing it with some insufficiently structured Pagetic bone. And we have this problem in the skeleton then. So that's the end of the story. That we're not going to go into the developmental aspects of bone beyond what we already have. We've talked about intramembranous ossification and the production of flat bones, the development of flat bones. We talked about endochondral ossification and the development of long bones. And so this is the end of our story. If you didn't catch all of the segments, go back and check out sections 1 through 3 of chapter 6 of Marieb on bones and bone tissues.